The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good morning, good afternoon, or good evening, depending on the time of day you are listening and watching. We are gathered here again for the next episode of TMD Demystified, and my name is Tony Urbanic. Today's topic is entitled, How to Treat TMD-TMJ by Organizing a Confusion. And as in prior episodes, please let me explain. That title may not be meaningful to you right now, but hopefully it will in a few minutes. Organizing a confusion is a very logical way to solve a problem, and I'll define that and describe that as we go through this episode. But my purpose in this podcast and each episode of this podcast is solely for the purpose of educating and understanding in all different aspects, temporomandibular joint problems itself, how to diagnose it, how to understand it, what is really going on with temporomandibular joint disease. And after a 13-year period of examination and study, academic and clinical, I have gathered a tremendous amount of information regarding this. And actually, as those that follow my episodes in this podcast will see that, frankly, it is very simple, not complicated. And that is my purpose, to make this simple, useful, applicable, and successful in actually treating the problem and making it a successful part of your practice, whether you be a general dentist, an oral and maxillofacial surgeon, or an orthodontist. Those are the three types of dentist in the dental community that are best geared for treating temporomandibular joint disease, because you are most likely to see these patients. The endodontist, the periodontist, even the pedodontist is not likely to see or be referred any number of patients with the symptoms of TMD. But let's start this progression on this episode very simply. Temporomandibular joint, TMD, TMJ, has been a confusion for a long time, all the way since its inception and first description by Dr. James Costin in an article he published in 1936, which led to the description of the symptoms and their association of the description of the symptoms of headache and earache, etc., to the temporomandibular joint. So early on, it was called Costin syndrome, and pretty much shelved until the late 50s and mid to late 60s. Let's just say late 50s and 60s, where it was pulled off the shelf and doctor types began kind of coning in on, well, what is this thing called Costin syndrome? What does it mean? Is it real? Can it be duplicated? And what do you do about it? And I'm not gonna go through the litany of the process of what happened in the 60s and early 70s, except to say that Daniel Laskin, who is an icon, literally an icon in the oral and maxillofacial surgery field, published an article I think it was around 1975, but basically described what he called the temporomandibular joint description of the myofascial pain dysfunction syndrome theory. And he even described it as a theory. He had no proof that the myofascial, meaning the fascial part of the muscle or muscle parts of mechanisms of the masticatory parts of the oral cavity were the primary causes of the symptoms themselves, mainly various and unusual pains around the face, mouth, and oral cavity. So Dr. Laskin published this seminal, good word, correct word, seminal article, which, among other things, led the profession in the wrong direction. And I say that sincerely and truthfully, and I can back it up. And then from there, in the late 70s, mid 70s and early 80s, the oral and maxillofacial surgeons got really involved because Dr. Laskin was a leader in oral and maxillofacial surgery from the University of Illinois and had a clinic devoted specifically to the treatment of temporomandibular joint problems. And a lot of oral and maxillofacial surgeon professors in different universities and schools and training programs got involved with trying to figure out a surgical solution for the temporomandibular joint problem. And my mentor, Dr. David Hall at Vanderbilt, who luckily I was able to obtain an internship and residency and medical degree from Vanderbilt because of Dr. Hall as my mentor. And I learned a lot of other things about temporomandibular joint from a surgical standpoint, and followed the leadership and the lead of many of my colleagues at the time who were senior to me. And I believed at that time that someone knew, some of my colleagues in the surgical area knew something about TMD, and that they were smarter than me, they had more experience than I, and they could, I could be certain that if I followed their leadership and what they wrote in their papers and their information that they disseminated, that I would be in good shape and relatively safe. And what I learned over the next 10 years from finishing my training program essentially in 1976 and applying surgical techniques and procedures in multiple different ways to the temporomandibular joint, that over the next 10 years, that number one, I was wrong. Those leaders did not know the answer or have the solution to temporomandibular joint problems. And I could spend hours talking to you about my experience, about why I finally came up and eventually decided that temporomandibular joint surgery was going nowhere, and I couldn't continue doing temporomandibular joint surgery for this problem, which led me to a non-surgical solution. But getting back to the point of this episode, that's the history which kind of solidifies and exemplifies the confusion that the doctors who were attempting to treat temporomandibular joint problems, TMD, found themselves in for 50 years, since Dr. Kosten described the symptoms and wrote his paper. And actually things got from bad to worse. And my non-surgical colleagues who tried to treat the problem basically tried various types of orthotics and got to the point where 50% of dentists were using night guards, claiming that that was the solution to TMD, literally a night guard of various kinds, various structures, various materials. And that proved to be bogus. But I don't need to go there either. What I'm trying to describe is how and why the mechanical features of solving a problem really has everything to do with organizing a confusion. And so what I've said so far in the past 10 minutes is TMD qualified and certainly qualifies even presently as a confusion. And that is my purpose, is to simplify this confusion, explain this confusion. So the symptoms of the disparate symptoms of TMD definitely are confusion. You have, if you talk to a PCP, a medical doctor of any kind, a neurologist who listens to these patients complaining of headaches and jaw pain and shoulder pain and arm, hand, finger tingling and numbness, and frequently they also throw in ringing, fullness, dizziness, and that the facial pains move around from one side to the other. And sometimes it hurts in the morning and sometimes it hurts in the afternoon. The medical doctors who listen to this think their patients are crazy. They actually tell them they think they're crazy because they can't make any sense of it. It's a confusion. And the dental doctors, they certainly don't tell patients they're crazy. I've never had a dentist, ever heard of a dentist had the gall to tell a patient that they're crazy, but I can tell you my medical colleagues have done that many times. All right, so it's a confusion. It has been a confusion. So how do you sort out a confusion? Now, this applies not only to TMD. I'm using this as an example and actually how I came up with the solution. How I came up with the solution, the mechanism that I used to come up with the solution. And I've spoken on it in other episodes, but in this particular episode, I want to get through for your benefit that you might be able to use it in other areas of your practice or other areas in your life or other problems you have that you are trying to come up with a solution that seems to be totally confused. And TMD is and was a totally confused problem. And so this is the important thing. If you want to solve a confusion, the first thing that you need to do is find a stable datum, basically a datum, a fact that is stable, that is not moving in a sea of confusion. Now, in preparation for this episode, I pulled up, and I'm going to look away from the screen here a little bit, a moment, but on my side computer here, I attended a seminar. Actually, it was dated February 6th and 7th, 2015. TMD and facial pain and headache was the title, and it was produced in Arizona, and there were eight major speakers brought from around the world to describe the problem and leading toward a solution. And these were, again, icons in the field back in 2015. I attended that Congress, and I thought, again, at that time, I thought that the folks who were speaking actually had the solution, and that's why I attended. And I found out that they didn't. But what I did find out was that man for man, speaker for speaker, what they did produce was a lot of confusing facts, thousands of confusing facts, literally over a 2-day seminar, which you could not make heads or tails out of. They are each individual significances. In other words, a significance is a fact, a datum that one thinks has importance, significance. And you can take any fact and claim it's important, but unless it leads you to the solution to the problem, it will take you nowhere. So what I learned attending this seminar, TMD and facial pain and headache symposium in Phoenix, Arizona, actually Scottsdale, I learned that there were additional, everything else I had learned surgically about the temporomandibular joint, there were additional thousands of facts that were of significance that led nowhere. So again, in solving a problem, you have to find a stable datum in a sea of facts that kind of just surround you, and you don't know which one is important, which one will lead you to the solution. So when I did my research about this, when I decided I was going to see if I could figure it out, when I decided I wasn't going to treat temporomandibular joint surgically any longer, simultaneously, because of my broad background in cell biology and anatomy, medicine, and dentistry, I decided that I was going to take a look at it and see if I could figure out what was really going on. And to do that, I started out where you should start out when you do any kind of research in medicine or surgery, and that is you start out with the patient who has the problem. Start out with the patient, not the textbooks, not the literature, not the congresses and symposium, and not luncheons, conversations with your colleagues. Start out with the patient who has the problem and begin there looking for a stable datum. And that's what I did. And I had no lack of patience because I was the primary maxillofacial surgeon treating temporomandibular joint in Nashville, Tennessee at the time on the private side. And I had a long list of patients who wanted to see me, but instead of bringing the patient in and listening to their symptoms, doing a few x-rays and gathering a few data, and telling the patient what kind of surgery I thought was best and that I wanted to perform, I recommended performing for them, I sat the lady down, because it's 90% females. I sat the female down and listened to what they had to say about this. And I encouraged them to speak. I would sit in a room with a patient for 30 minutes, 45 minutes, and encourage them to tell me everything they could tell me about their symptoms, or what they thought about the symptoms, what made it better, what made it worse, what phase of the moon was it when it hurt, how their symptoms moved around, what their husband thought about it, what the weather was like when it hurt. And I wanted to just have the patients tell me everything that they could tell me about their symptom, their problem, and everything that they knew about it. I was looking for a stable datum. I interviewed 24 women. Out of 24 women, 12 of them roughly told me a fact, among many other facts. I heard all kind of things. Some of the things I knew, some of the things I didn't know. But I heard 12 times out of 24, if I put my finger, a pencil eraser, my tongue, or a piece of cloth between my front teeth and gently bite down, it feels better. In other words, the symptoms subside. After I heard that 12 times, it registered that that was a stable datum. I mean, no matter, these patients, 24 patients, had all the various symptoms, and not all of them had the same symptoms, and they ranged in ages from 16 to 70. And they came from different areas of Middle Tennessee, and they had all kind of different history on their symptoms, some of them short-term, some of them long-term. But 12 out of 24 told me if I put my finger, a pencil eraser, my tongue, a piece of cloth between my front teeth, it feels better. And I felt that was a stable datum. So I went in my laboratory and I made a device that went between the front teeth that I thought the patient could speak with, because if you're going to wear it more than nighttime, and I felt that that was the right thing to do to test it out, it was a test. That was the right thing to do, was to wear it full time to begin with, something they could speak with. So I made a device that fit behind the upper front teeth and separated the back teeth, which is, if you only front teeth touch, then that naturally separates the back teeth. And I gave it to the first lady in line, who had 20 years of headache, earache, jaw pain, neck pain. And I said, put it in your mouth, keep it in your mouth 24/7, except when you eat. You have to eat, so take it out of your mouth when you eat. You can't chew with it in your mouth. After you eat, you brush your teeth, you brush your device, put it back in your mouth, and come back see me in 3 weeks. She came back in 3 weeks. I walked in the room and I said, how you doing? And she looked up at me and she said, thanks, doc, my pain is gone. And that is where it all began. That is all where it began. And the patient themselves, actually, the patients themselves, gave me that stable datum, which is put something between my front teeth and gently bite down, it feels better. Well, the rest of the story, it's been published, and I've talked about it on other episodes a few times, but having a stable datum like that, then I continued and did another 30 patients with the device, and all of them came back over time. Not all came back in 3 weeks and said 100% of their symptoms are gone, but they all came back over a period of time, roughly the first 2 months, and said their symptoms, whatever they were having to do with TMD, were significantly better. I mean, significantly better, in the range of 70, 80, 90, or 100% within a few weeks to a couple months. We now know that the average patient will come in and give the average number of symptoms diminished or gone, how much of it is gone, diminished, decreased, at 3 weeks is 70%. That is the average. Of course, some less than 70%, some more than 70%. But the point is, after reaching the point where I had 30 cases under my belt, I had no idea what was going on. I had no idea the mechanism why placing something between your front teeth according to a protocol, starting out 24/7 for 2 months and then going to nighttime only the rest of your life, what was going on there. And that was the rest of the story. And that was fairly easy to understand. And again, I've discussed it multiple times. I'm not going to repeat it here again. You can look it up easily at multiple episodes or on our website. But bottom line is, inflammation in the temporomandibular joints subsides when you unload a joint. Just like when you have tennis elbow, and the proper treatment for tennis elbow is to put the elbow in the arm and the elbow in a sling. Rest the joint. Rest the joint. That is the first line of defense on tennis elbow. Not surgery, not drugs. Put the arm in a sling. Rest it. And since tennis elbow and TMD are the same disease, what you're doing with a posterior disc occluding device that can be worn 24/7 according to the protocol allows the inflammation to die down, which drives all the symptoms. Each and every one of those symptoms is driven by inflammation within the temporomandibular joint, anatomically, cell biology-wise, endocrine-wise, neurologically, driven by inflammation within the temporomandibular joint. And so when you unload a joint, any joint, and the inflammation goes down, when it comes to the TMJ, headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking subside. And it all started out with a common denominator, basically a fact that could be one fact that you could count on that was unchanged, started the whole thing. And that's how you organize a confusion, an unknown. And the more unknowns that you're working with, the more important it is to start out with a stable datum. In this case, obviously the stable datum was to put something between the front teeth, and then we figured out how that worked. That's called inductive reasoning, not deductive reasoning. Sherlock Holmes used deductive reasoning. He had multiple pieces of data out there that he picked and chose, and he was, quote, smart enough to pick and choose the right pieces of data to explain who was the perpetrator, Sherlock Holmes. That doesn't work in science all the time. That does not work in science all the time. And this particular scientific breakthrough, because it is a paradigm shift in understanding and treating TMD, started out with a stable datum that went around all of those significance, those thousands and thousands of facts that had been published and talked about and spoken about at a 2-day symposium. This particular speaker that I'm looking at here on my other computer talked for 2 hours on the different forces that are on the temporomandibular joint, how the forces were measured, how the different sizes and contours of the meniscus itself changed within the different forces. He went for 2 hours with that. Each one of those facts, probably in that presentation, he had 300 facts. All of them, quote, significant, meaning, well, which one is important? And actually, none of them were important. None of them. No matter how much damage is done within the temporomandibular joint, no matter how much scientific facts can be brought about the changes within the temporomandibular joint, the most important feature is inflammation. Damage, it does do damage, doesn't make a difference how much or where, but causes inflammation and degenerative change within the temporomandibular joint, but it's the chronic inflammation that drives the symptoms. All right, well, that is what I have to say today about this, and I hope that I made the point logically that you might be able to use it. I did this presentation, this episode today for 2 reasons. Number one, to further explain how it came to be, because when I describe this for other doctors, I mean, they're happy to read the study that we have, the independent university study that proves what our claims are, that 85, 90, 95% of patients have significant decrease in symptoms. They're happy to read the paper, but what they really are more interested in when they talk to me is how did this come about? I mean, how did you figure this out? And so basically that's how I figured it out and started out looking specifically for a stable datum, hoping that I didn't know whether I'd find that stable datum in talking to patients, but I knew that I didn't know the patients had the key. They gave me the key. I was hoping that I might find that one stable datum that we could start working with that was true for all. Again, the stable datum is true for all parts, all types of the disease. And that was this. From there on in, it was inductive reasoning. It worked. Then we had to go back and figure out, well, what's really going on when you separate the back teeth. That was pretty easy to figure out when you understood a little bit about tennis elbow and my colleagues teaching me about joint splinting and tennis elbow as it applies to the tennis elbow and applies to the temporomandibular joint too. If you would like to learn more, and there are a few more details, not many, and there are a few nuances about treating temporomandibular joint with a device and protocol that works really, really well and is a change in paradigm totally for treating this problem. If you'd like to join the network of doctors throughout the United States who are doing this, you can jump on our website at www.urbanictmj.com and look it over. There's a tremendous amount of material there, including multiple episodes of a blog that I write also once a week. I try to make the weekly blog parallel to the episode of TMD Demystified podcast here on Dental Town, so that we're talking about the same thing, one written. The blog is designed primarily for patients. The episodes on Dental Town are designed primarily for doctors. But if you would like to look at that information or get more information about how to become a network provider, it's on the website. If you'd like to talk with me personally, get in contact with me. I can be reached at Tony@tmjservices.net. be happy to discuss it with you, meet you. Or if you'd like to take an in-person course on becoming a network provider and licensed to use the patented device itself, we have our next in-person course here in Nashville, Tennessee, and beautiful Franklin, Tennessee, Cool Springs, Franklin, Tennessee, on July 26, 2024. And that can also be registered. Registration for that can be done on our website. And I'm open for criticism. If you'd like to criticize what I have to say, I'll be happy to discuss it with you, but be prepared. If you're going to criticize and discuss it with you, be prepared to bring the science into it. Please be scientific as to what you have to say and not just throw significances at the wall. You know, in my blog, and this is the last thing I'll say to wrap it up, you know, we got to the point in treating temporomandibular joint problems over the past 50 years, or even going back that little further than that, 60 years, by both the surgical and non-surgical doctors, dentists, oral and maxillofacial surgeons, and general dentists. We're trying to treat this just by throwing things at the wall to see whether they stick. I mean, try this, try that, throw it at the wall, see if it sticks. That is not a good way to practice science and practice the scientific method and try to treat patients. Throwing things at the wall and see whether they work. Looking for a stable datum, finding a stable datum and see how that works, that's a different story than just throwing things at the wall to see whether they work. So we started out with a stable datum that the patients gave me the key to use, and that started the whole ball rolling. With that being said, I invite you to tune in to the next episode, which will be in 1 week. I have these episodes done once a week, every Tuesday. Until then, I am Tony Urbanic. I look forward to speaking with you again. This is TMD Demystified.